Hello, everyone, and welcome to the second season of McGill Cares, a webcast supporting family and informal caregivers. I'm Claire Webster, a former caregiver, certified Alzheimer care consultant, and founder of McGill University's education program. I hope that you all had a very happy and healthy summer, and we're very excited about launching the new season of McGill Cares. For those of you that may be new to our webcast, last year we recorded 47 episodes that are available for free on demand at mcgill.ca/dementia, which cover a wide range of topics and that are really geared towards family and informal caregivers, medical students, healthcare professionals, and the general public. And our webcasts have also been converted to podcasts that are available on Spotify for audio listening. I work with a dynamic team of leading healthcare professionals to oversee the McGill Dementia Education Program, who include Dr. José Moret from the Division of Geriatric Medicine, Dr. Serge Gauthier, Professor Emeritus, formerly of the McGill University Research Center for Studies in Aging, and Dr. Gerald Fried, McGill Steinberg Center for Simulation and Interactive Learning. These webcasts are made possible thanks to the generosity of donors, and we would like to thank the Zeller Family Foundation for sponsoring today's webcast. Well, I'm very excited to kick off this season with the topic of the urgent need to improve the lives of Canada's elders. My very special guest is health columnist at the Globe and Mail and the author of 6 books, André Picard. He was named Canada's top newspaper columnist in 2020 and is a recipient of the prestigious Michener Award for Meritorious Public Service Journalism and the Owen Award, the highest honor granted to a non-physician by the Canadian Medical Association. Mr. Picard will share the findings in his current bestseller, Neglected No More, The Current Need to Improve the Lives of Canada's Elders in the Wake of a Pandemic, about what can and must be done to improve the state of care for a vulnerable population with complex needs and reduced ability to advocate for themselves. Welcome to McGill Cares, André.
Hi, and thanks for the invitation.
I have to say that I really, truly devoured your book. It really touched me personally because of my own journey. And, when I was reading the book, I didn't feel like I was reading a book. I actually felt like I was sitting watching this incredible documentary and film. And it was not only a very personal journey reading it, but a very educational experience, like truly educational. So first of all, congratulations on this amazing resource.
Oh, thank you.
So I think just to begin, I'd really like to understand, why you wrote the book, and I know that you had a personal journey, so maybe you can share that with us.
Yeah, it was really a mixture of the professional and the personal. So I've been a long time health reporter. When you write about healthcare, you write about elders because people, get old, they get sick, etc., and they dominate our health system and delivery, and the need for care tends to be older people. So I write a lot about seniors for a long time. And then, as you mentioned, I had this personal journey, like many, many families, nothing unusual. But my dad developed dementia, ended up being Lewy body dementia. So a long, slow degradation, long-term in all parts of the system. And then later, my mom, who had COPD, lung disease, ended up with vascular dementia. And then kind of a shorter journey was more sort of short and brutal, but those 2 forms of dementia. And I always say, as a journalist, that was kind of my education in healthcare, an education I wish on no one, but an education I know that many, many of us need and will have, unfortunately.
Mm-hmm. So what, I've read the book and I was highlighting so many different sections of it, but so what are the primary problems with the way seniors are cared for across the country, both in long-term care residences and in the community?
I think there are many, many problems. It's a book length answer, but I think I always start with just the practical. I think we have this ingrained ageism in our social policies, and it's reflected in many, many ways. So I think, to me, what we really need to do fundamentally is to say it out loud and say it in our policies that elders matter and we're going to ensure that they live out their lives in dignity and with respect. And once you do that, and I think Canadians really have that philosophy individually, but if we have that philosophy collectively in our policies, I think a lot of things change and change quickly. So you know this better than I as a caregiver. What makes the life of caregivers difficult? It's accessing care. It's the system is incoherent, moving between your needs. You don't get support. So we literally work caregivers almost to death. We expect that before they get even a little bit of care. And then just the frustration of once you're in the system, how you're treated, you're kind of sloughed off to the side. It's not covered by Medicare like other things as you expect. So there's a long laundry list of what's wrong. And I try to, in the book, sort of get into issues chapter by chapter. And it's designed to do that, to be a bit of a guide and help people understand what's coming. So I would really hope that people read this before their care journey, not after.
Yeah, I mean, I think we're going to get into it a little bit after, but I think what really stands out, and you said it so clearly, is like when the time comes that you actually need to access support, we have no idea how to navigate the healthcare system. Like, what is available in the public system? What is a long-term care center? How do we get in? You talk about what the difference is between the private sector versus the public sector. How do you get into the public sector? Like, it's this there's so much out there, but we don't even know how to access it. And I was even feeling, for instance, even some very good organizations, for example, like the Alzheimer's societies, I didn't even know that they existed. Right. So, I mean, I know that you interviewed a lot of families. Was that loud and clear that people didn't even know how to access support?
That was a big theme, that, the system is enormously complex. It's hard to figure it out. And what makes it worse, I think much worse, is that we always end up in the system at a time of crisis. This doesn't happen when things are going okay and you have to, I can figure this out. I'll take a few months. You have to figure it out in minutes and days. Often there's a crisis that occurs. Say you have to go to long-term care. You have a matter of hours to decide. Here's a spot. You have to decide. If you don't decide within 24 hours, we're giving it to someone else, and you're going to wait again. There's all of these pressures in the system, and really a lack of information. There's no hotline to phone and say, I don't know what to do with my mom. She's acting weird. In the early stages of dementia, some of the hardest stuff, and it's the area where it's almost the most difficult to get really basic information. So that's a theme throughout. We just have to make it easier for people to care. We'll talk about this later, but there are many caregivers, and they give this care lovingly and willingly, but we have to make it easy for them to do it. And that's not a big ask for the system. It should be the number one priority.
Mm-hmm. So you devoted, an entire chapter to the specific needs of elders living with dementia. How do the weaknesses in elder care play out for people living with dementia? I mean, we know that, I don't think only nationally, but on a global basis, the majority of people who died from COVID in long-term care facilities had dementia. So how is the system failing that population?
So when we talk about COVID, I think that context is important. There's been about 26,500 COVID deaths in Canada, a lot of deaths, but more than 17,000 of them were people in institutional care. So 2/3, like an enormous amount. You can't overstate the gravity of this calamity in care homes. And those care homes are almost all people with cognitive loss, and a lot of them full-blown dementias of various sorts. So that's who died during COVID. It was people with dementia. And we have to frame it in that way to recognize how vulnerable they are. These are really the most vulnerable people in society, and we abandoned them and we didn't take care of them. They're forsaken, is the way I say it in the book. So why are they so vulnerable? Well, we know anyone who's had a loved one with dementias, they just need that basic care, feeding and toileting, etc. And that's what the homes fail to provide adequately. They need a different kind of companionship. They need different kinds of guidance because of the confusion that goes along with the illness. And that was cut off. We cut people off from their loved ones who are really they're linked to the world and to the past. So what happened in these homes was it was not only deadly, but it was cruel. And it was especially cruel to people with dementia and to their caregivers. Because we all know, I many times during the pandemic said, I'm so glad my parents have passed away. I couldn't have survived this, knowing that they're on the other side of this window and they don't understand why I'm not there anymore. Like that's just so heartbreaking for so many people.
Yeah, and what I find too, because I've lived the journey of my mother, and she passed away in a long-term care facility before COVID. But as the disease progressed, they're no longer able to communicate. They're no longer able to advocate for themselves and express their wishes. And so, when we talk about the lack of training of personnel, it gets to the point where, training is so essential, because as a person can no longer express how they're feeling, you have to almost be a detective and really understand what is physically going on. So this population is made even more vulnerable by their inability to verbally express how they're feeling, what's going on. So, which leads me into the next question. What did you see in terms of the greatest challenges that, the personnel are facing in long-term care?
Well, the personnel, is a twofold problem. One is just the sheer numbers, the inadequacy of the staffing. So that was probably the number one contributor to the deaths, to the failures in COVID, was we just didn't have the people to care in a time of crisis for a whole bunch of reasons. And then you mentioned the training, and the training is really important. And that's none of these issues we're talking about is new. They were just put under this giant magnifying glass by COVID. But training to me is from physicians on down to nurses to personal support workers. The training is inadequate in our health system because, as we talked about earlier, the vast majority of care is for seniors, for frail elders, and we don't train people specifically for that. It's as if they're an afterthought, and that should be the starting point. It shouldn't be, let's have our class on geriatrics today. Healthcare should be about geriatrics, and the other stuff should be added on, because that's the reality. So we have to adapt our education to the demographics, and we haven't done that. And it's particularly striking with the workers. They have different names across the country, but care aides or personal support workers. In Quebec, it's often orderlies is the word that's used.
Or PAB, préposé aux bénéficiaires.
Yeah. Préposé is a common one in Quebec. And they get very little training. There's very little regulation in the country. So some people have a college course. They get trained on, how do you bathe someone with dementia? That is an art form. It's something that has to be taught, and it's really, really difficult. Anyone who's tried it knows that, wow, this isn't easy. So they really need training. And in some parts of the country, you can literally just hang up a shingle and say, I'm Bob's préposé, and you can hire me. And you say, what's your training? Well, here's my certificate that I printed out at home. Yeah. There's and people, there is abuse because of that, and there's inadequate care. Now, a lot of our workers are well-intentioned and loving workers. A lot of them we know are from the immigrant population. This is a very racialized workforce because people don't want to do this work. Quebec was, particularly shocked the world during COVID when people learned things like their préposés, their orderlies were being paid $13 an hour to do the most difficult, intimate work you could imagine. It's an obscenity how little they were paid and taken care of. So a lot of stuff that we should have known and should have dealt with before COVID was exposed by the pandemic.
And there was also, you talked about, for instance, that, in some of the private residents, for example, the staff are not being properly paid. There's no benefits, so they had to work at multiple facilities. So I think a lot of people think because they go and they're spending $8,000 to $10,000 a month in a private residence that they're going to have the best, most well-trained staff, which is not necessarily the case, correct? Because they don't get the benefits. They're not necessarily receiving the training, in all cases. So they have to work at multiple facilities. And that's how I think some of the COVID was spread.
Oh, it was the principal way COVID was spread. It was this, we have casualized that workforce because we don't want to pay benefits. So they work shifts at all kinds of different places. And through no fault of their own, I don't blame the workers in any way during this pandemic. They carried the the virus around between homes. So that was we know that the provinces where there was no movement between institutions had very little COVID in the homes. It was very clear how we could prevent this, and we didn't do it. And, the workers have to do this to barely make a living. And it shouldn't be that way. So, we need proper pay, we need proper benefits, and things like paid sick day. People were sick and didn't take time off work because they couldn't afford it. Their family literally would go without eating if they did that. And again, that spread COVID as well.
The other part of what you wrote about that really stood out was the fact that in a lot of these residences, now I don't recall if it was just in the public or if it was in the private or both, but for instance, the medical doctor that's on call, and many times is a retired doctor. You don't even have somebody on call permanently, right? Who's not there on a day-to-day, so it's on call. And also you mentioned the fact that there just weren't enough nurses there. So maybe you can elaborate a bit on that.
Yeah, so people don't realize that. They think I'm in a care home, there's going to be a doctor, there's going to be nurses, but these are the highest need patients in our country. And most homes just sort of have I called them a doctor by fax. So someone who literally would fax in orders, the nurse would call in and say, okay, yeah, refill that prescription. There's very little hands-on care. There's often this revolving door to the emergency room. Any little thing that happens to you in a care home, you go in the ambulance and you go to the ER. And again, for patients with dementia, that's really, really upsetting and confusing. And they degrade because of it, just because of that lack of care. Now, I have to say Quebec on that count is a bit better. Quebec has a lot more physicians in their homes full time. It has a more public system. It's more integrated into Medicare. So Quebec does deserve kudos on that count. But even with that, they were overwhelmed by COVID. One doctor can't make a difference in a home of 200 people. And that same thing is true of nurses. These homes, in Quebec, they have a different name, CHSLDs, but in most of the country, it's called a nursing home. And the reason is they used to be run by nurses, but now nurses have been kind of shunted out because they get paid decently. And often there's just one nurse on a shift for 200 people at night. So there's not enough nursing either. So there's all these issues. You mentioned the private public. We can talk about that a bit more later if you want, but that is an issue, but it's one that gets simplified and becomes dogma. The homes all had problems, private, public, municipally owned. They all had similar problems, but in different ways.
So let's just talk also briefly about, in terms of staffing, when we talk about home care support. So prior to COVID, I'll use Quebec as an example. To get home care support, you have the assessment from the doctor, you call the CLSC social worker. It may take up to 6 months for somebody to come and do an assessment, right? And then, in general, they're allowed maybe for average of 4 hours a week, right? That was before COVID. COVID happens, and then all of a sudden everything just stops, right? So you mentioned in the book about how during COVID, the people the PABs that were working in home care, all of a sudden there was this opportunity now to go work in long-term care. So explain what happened, that shuffle.
Yeah, I think that's an issue that we as journalists didn't cover very well during the pandemic, is that home care really collapsed. What happened is we put a lot of our efforts and time into institutional care, and then they just went and got workers from the home care sector. Or in many cases, they just suspended home care. We want to protect vulnerable people from COVID. But what was the answer? The answer was to put them in these homes that were 100 times worse in terms of risk. So there's again, it's just an example of how our system is not connected in any logical fashion. So home care, to me, is really important. I think in Quebec, it's particularly underfunded and neglected. It's fundamentally, people should have a choice of where they live out their final days, and we don't give them choice. We have this default setting of we're going to put you in an institution, and the default setting should be we're going to keep you in the community as long as humanly possible, because that's best for you, and it's best for your family, and it's best for the community. And the countries that do care well, that's exactly what they do. They say home first. There's no place like home as an expression, and it's very, very true for people who are aging. But that being said, some people do need institutional care. There's no question. If you need 24/7 care, you're a patient with dementia who wanders, you need that safety. But then it doesn't have to be a home that looks like a prison. It should look like a home. And again, one of the things that people have been most fascinated about by my book, I was surprised by this, but was when I get into the history. The history of care is it came up through the penal system. It didn't come through the health system. We used to take the indigent, people who had no money and they were getting old, and stick them in a workhouse and say, you got to work essentially for your gruel, quite literally. And this was true in Canada and Quebec well into the 1960s, that people were just pretty well treated like prisoners who should be thankful for getting their room and board from the state. So that attitude is ingrained not in the people anymore, but in the structure of the system. And then home care came up through the religious side. We're just going to pity you a little bit if you're at the home. But then we took what was actually a much better system 100 years ago, and we just degraded it because we got rid of all those nuns who did this work so voluntarily, were eased out, and we brought in paid nurses, and then we got rid of them because they had to be paid. So there's all these things that happened historically that resulted in the place we're at now, which is it's very, very difficult to get home care, as you said, even though every poll time after time tells us, you ask anyone, and I do this back in the days when we used to get a room full of people at a talk, when we were allowed to congregate, I would say, who here wants to live in a nursing home? That no one would ever lift their hand. And who wants to live out their life at home? 100% of people would raise their hand. And why don't we give people that choice in our system? That the system should be geared to the needs and the wants of people, and it doesn't.
Well, you're so right about the history, because I work with families on a regular basis, and the fear is, they make their kids or their spouses promise to not put them in an institution, and they often use that word institution. And when I hear the word institution, I think of the movie One Flew Over the Cuckoo's Nest. With oh my gosh, I'm having a blank now, but that famous actor
Jack Nicholson, yes,
Jack Nicholson. But that's that you're going to be there and you're going to be strapped, and you're going to go to the nurse and you're going to be put in a room and just like in solitary confinement. And I think that's a real fear that people have, to the point where I've worked with families where, they put in their will that in the event that a spouse passes away, they make it so that a son or a daughter will be the one responsible for caring for that person at home, right? And which is a very difficult commitment to make, but that stigma about long-term care facilities being institutions is very, very real and very scary for a lot of people.
Yeah, absolutely. And we have to remind people that sometimes it is necessary, but we have to make it dignified. And that's what people fear. People fear living out their life in an undignified fashion. And I think that has to be job one, is to make sure people live out those final days in a way that's decent.
So a lot of people watching today are family and informal caregivers. And, the chapter that really touched me the most was chapter 7, Conscripted by Love. And in particular, you discuss the challenges that the sandwich generation, meaning, and people say, what is a sandwich generation? And anywhere between 35 to, let's say, 55 face in caring for, we're caring for children and teenagers. And then we have our aging parents, and we're trying to balance our careers. And then we're trying to care for a loved one that has an illness. And in one of your books, it was a wife caring for her husband. It could be a son or daughter caring for a parent who has dementia. But we have all of this weight of responsibility without the necessary skills, training, education, anything at our disposal. So maybe talk about what are the biggest challenges that you saw.
Yeah, so I think we had, again, to understand the demographics, there's like 7.8 million caregivers in Canada. So a lot of people do this and they're not ready for it, but they do it. 10% of them, about 780,000 people, provide care to a loved one more than 50 hours a week. So this is an entire full-time job, a really hard full-time job, and it's on top of their paid work. It's on top of taking care of their children. It's on top of having a relationship. This is really overwhelming. Now, what's really shocking to me is that most people do this lovingly and they do it voluntarily. And again, we just have to make it easier. We have to give them release the pressure valve occasionally, a little bit of respite care, more home care. People don't want to turn their loved ones over to the state full time. They want to do what they can, but they have the inability to do a lot of it, especially, the sandwich generation you mentioned. We didn't talk about this, but this was COVID. COVID was a crisis rooted in sexism and racism and ageism. It occurred at that intersection. It was women caring for loved ones, racialized women caring for loved ones in care, and elders being neglected because that care was inadequate, not because of the people, but because of the system. So that's really a fundamental issue that has to be addressed. So we have to support those unpaid caregivers. That's probably one of the number one priorities we have to tackle.
I mean, before COVID happened, my journey as a caregiver began in 2006. So everything that was at Pandora's box revealed. For instance, in the long-term care centers, I lived through with my mother. I was a caregiver to my father when he was in the hospital system and wasn't able to, advocate for himself. But, before COVID, for instance, when we talk about dementia, if you receive the diagnosis and it's basically, for my case, it was like, good luck, Mrs. Webster, right? There was no information. That was before COVID. So then COVID happens and there's even no information, but now there's no more resources. There's no respite. All the activity centers stop. And so you have all these carers looking after somebody at home without any skills. And I had an aha moment with you in your book because, I talk often about, when you're caring for somebody with dementia, it's, helping them, the bathing, the dressing, the feeding, but then you even go deeper and say, well, what if you have to change wounds? What if you have to change a catheter? Like, where are people getting that type of training, right?
Yeah. And we expect that of people now. The system is very onerous. What do you learn? You get 5 minutes at the hospital. Oh, we're discharging you. Do you know how to put in a catheter? Here it is. And you watch. And you've never seen, you never imagined anything like this in your life. And then you're off home to try and do it. And there's a cost to this, to the system. People get more infections. They end up in the ER, never mind the trauma on the carers. But so there's all kinds of consequences to this, the way we neglect people, teaching them to care. I mentioned in the book too, I draw this parallel. Nobody has a baby anymore without their parenting classes, right? Everybody takes their parenting classes. Well, I can tell you, you've been through it, so have I. We need less parenting classes and more how to care for your parents classes because it's way, way harder. Bathing someone who weighs 5 kilos is really, really easy compared to someone who weighs 60 kilos and is resisting. Feeding a baby is way easier than feeding a 75-year-old who's reliving a trauma. These things, they don't compare. They're 10 or 100 times more difficult. Why aren't we training people? It seems like an essential role of our system to do that. And we don't. You said it very well. Here's your diagnosis. Goodbye. Good luck.
Because even if the government tomorrow was going to say, I'm going to inject, here we are, we're going to make a commitment and inject all kinds of money in home care support. When you're caring, for example, for somebody with dementia, which becomes 24 hours, 7 days a week, there is never enough home care. So inevitably, and even the people that can afford to pay for the private help, inevitably, it does fall in the hands of the carer, because if the person that is coming to help you is sick, if that professional caregiver is sick, you have to step in. So you need to know the basic skills to be able to step in at any given moment. But we're not getting that information. We're not getting those tools. One in your book, I was so pleased because the word that you use, first of all, you use the word prescription a lot. Prescription. I use the word prescription of care. So what is that prescription? But what I was so pleased to see is that, one of your words of wisdom to families is you need to plan ahead, right? Like we need to plan ahead. So can you elaborate a bit on that?
Well, I think, as someone who's talked to families of elders and frail elders and people with dementia for many years, that's always the biggest regret. I wish I had known X or Y or Z. These really, I say in the book, the most important conversations we can ever have are around the kitchen table. We have to, when people are of sound mind, when they think it through, we have to talk to our loved ones about, what do you want? How do you want to live your life? And then how can I make it easier for you? I mentioned before that almost all these decisions happen in a time of crisis. So we don't like talking about death. We don't like talking about illness. So we put it off. Then your mom has a stroke and she goes to the hospital and you gather around the bed. And then, she's there for weeks and they say, listen, she's in pretty severely disabled. She has to go to a home. And you're like, well, we never talked to her about this. Mm-hmm. And you have to decide. And then they say, oh, if you're lucky, it's not 6 months in the hospital. They say there's a bed available, but you have 24 hours to decide. Yep. We only have one that's 200 kilometers from your home. Can you do that? Well, I'm the 75-year-old spouse. I don't drive anymore. I'll never see him again. These are life-changing moments that occur. And if you're prepared for them, they're so much easier to make. These are never easy decisions, but they're much easier if you're prepared. I'm lucky that I write about this stuff. I hear people's horror stories. I had the opportunity to sit down with my parents and say, well, what do you want? Do you want a DNR? Do you want a do not resuscitate order? When you go to a home, what's important to you? Mm-hmm. And my father would say, well, it's important that my wife be close by. So that became the deciding factor. But if you don't know this stuff, it gets hard. And family dynamics, everybody knows this. Mm-hmm. Families have their issues, but those issues become much more intense in these times of crisis. So what do you do when you have the sister who doesn't want you to go to the home at all costs, and the others who say, I can't contribute, I have my kids at home, I have a job? These things destroy families. And that crisis can be avoided if you said clearly, when I have this, I want X, then I think the children will go along and there'll be less of that fighting. So sorry for the long answer, but I know,
but it's really and I when I'm meeting with families, I meet families when they first receive a diagnosis or they may be in the middle of the journey. I ask them 3 questions. First question is, how much do you know about the disease? Like, what do you know about it? Most of them say no. Second of all, I ask them, so who has the mandate or the power or the notarized power of attorney? And they're like, what? And I have to say, majority of them, what is that? What? And then the third question is, I hate to ask this, but do you have your finances in order? Because if you're not able to access help from the public system and you need to make a very quick decision to go and get some temporary private resources, what are the finances like? And COVID showed us that families were separated. So you had oftentimes the aging parent, dementia had progressed, the daughter or son was living outside of the country, and who is then making the decisions? And unfortunately, dementia is one of the most expensive diseases to manage. And if you don't have that power of attorney and you don't have the finances, there's a problem.
Yeah, in Canada, we have this fantasy that we have Medicare and everything's going to be free. We're going to be taken care of. And it's not the case at all. It is very costly. The money issue is a really important one. Quebec, again, if you live in Quebec, you're luckier than most of the country. There's more state provided care than most provinces. But if a long-term care facility, a bed can cost anywhere from $2,000 to $15,000 a month. And people are shocked by that. They have no idea. They say, I'll be taken care of. You're not going to be taken care of. And if you have no money, you're going to be in the state system. And it is, to be honest, I hate to say this, but it is second-rate care. If you're getting subsidized care, you're almost certainly going to be in a wardroom. You're going to be sharing a room with 3 or 4 people. Is that, imagine someone who's had a good job. They've been working in the community as a plumber their entire life. They have their home, they have their community, and then they're sent where? They're sent to summer camp with 3 others in the room who are dying. This is not how people want to live. And people, you've heard this. I know, I'm certain you've heard this many times. I'd rather be dead than be there.
Yes, over and over.
We should never have a public service where people would rather be dead.
Now, I think one thing that I think is very important for families to remember, what COVID has taught us is that you need to have a plan A, but you need a plan B, because we don't know what can happen. So, as much as families may decide, okay, we're going to sit down, we're going to have a plan, right? So if, for instance, the spouse passes away, this was going to happen, but it's very important to have a plan B. So for those people that, yes, you want to live at home for as long as possible, but if it gets to a point where it's not possible, again, because perhaps of dementia, what's your plan B, and do the proper research in terms of what are the long-term care, both in the public and healthcare. But you have to do your research earlier than later, not when a crisis occurs.
Yeah, and I remember someone saying to me in my research, saying, this was a person who had a plan, and they said, and then dementia came, and it was like a stick of dynamite was thrown into the plan. Everything blew up. And that can be the reality for many. But having a plan and A and B you're right, is really, really important.
Yeah. So tell us, because you did look around the world and you were looking at the different healthcare systems. Which countries are doing the best and why?
Yeah, I always have seen Denmark as sort of the gold standard around the world. And why? I think people think when I tell them that, they say, well, they're a Nordic country, they spend a lot more money. They don't. They actually spend less than Canada does on healthcare. I think what they do fundamentally, the single most important thing they do is they have that philosophy that I talked about at the outset. They made a decision. And they made a legislated decision. They put their principles into law. They said, we value elders. They're going to live in the community. They're going to be visible. And we're going to adjust the system to that way of thinking. And we don't do that in Canada. We do the exact opposite. We say, I think we have good values in Canada. I think we all love our moms and our grandmothers. We love them individually. We want the best for them. But that's not what our legislation says. Our legislation, when you read it, what does it say? It says, when you get old, we're going to stick you in a building off by the highway, and we're going to treat you like a widget. You're going to eat when we tell you, and you're going to wake up when we tell you, and it's going to be difficult for your family to see you. And God forbid that the public ever see you. Our elders in Canada are invisible, and those with dementia are doubly invisible. When I go to Denmark, I'm really struck. A long-term care home looks like a family home. You don't know the difference. You walk down the street. They're always near a school or near a daycare center. They interact. Children see people with dementia every day because they respect their elders. And this is the reality. This is what your grandma's like. And kids, have so little judgment. It's one of the best things. I think every care home should be attached to a daycare, because that link, that symbiosis is so important for the people living there, and it's good for the kids. It's just normal, and it should be.
So in your book, in chapter 12, you talk about your prescription for reforming the way we care for seniors. And I love how you say governments spend so much time with all these plans and strategies and consultations and committees. And I mean, I've been a part of a few of them, and I'm like, gosh, stop the talking. Let's start doing. Okay. So can you go over, give us some of the highlights that need to change?
Yeah, so you mentioned there have been 150 reports since the advent of Medicare on how to improve care for elders. So we know everything that needs to be done. We know how to do it. We have tremendous recommendations, and it's just all about implementation. It's about, we know the system's broken, fix the system, and we know how. So that it's so easy to do. That's the frustration for me. It's not that much more expensive. We've costed it out. There was just a report last month. How much would it cost to make our system decent? It would cost $13.7 billion. That's not a lot of money. That's 4% of our health budget. Would you pay 4% more taxes to have your loved ones cared for? I'd love to put that to a referendum. I think it would get a pretty high majority. Now, so to answer your question, what needs to be fixed? I think number one is the philosophy, which I've referred to a couple of times. Let's give life to our values. And let's do it in legislation, and then everything else can happen pretty quickly. So what are the technical changes that need to be made? I think it all begins with people. Healthcare is about people, caring for people. So we have to get the staffing right. We have to mandate a minimum number of hours of care. And this is starting to happen in Canada. It's starting to happen in Quebec. You need, the research is quite clear, a minimum of 4 hours of hands-on day care per day per person. Right now, there are very few provinces that even provide 3. And those are averages. So some people just get nothing. And when I say you need minimum 4, some people need 10. And that's not unreasonable. So we have to build that. The basics are there. Everybody gets There's some care every day. So that's the big one. I think one of the things the pandemic really revealed is that the conditions of work are the conditions of care. That's a famous saying by Pat Armstrong, who's kind of a legend in the long-term care field. And that was the most important lesson of COVID. When you underpay workers, when you understaff, when you don't have benefits, when people move between facilities, you get crappy care. Who had no COVID cases? The people with long-term stable staff. It's a very simple answer to know how to prevent deaths. There are many homes around the world that didn't have a single COVID death. In Quebec, we had several homes that had more than 100 dead, 50% mortality. I often use the comparison. Imagine if 50% of children in a daycare died. People would be at the National Assembly with pitchforks. But because older people, they're old, they were going to die anyhow. And that wasn't true. That was never true. And I think I got distracted from answering, but so the is number one. And the second one, again, it's about people, is support for caregivers. They do unpaid carers, family members mostly, do the bulk of care. Whether you're in an institution or not, that's the reality. They do the bulk. When my dad was in a home for 7 years, my mom was there every day, 3 meals a day to feed him. She was there to read to him. We don't have people, there's not enough people to do that. You have to have loved ones. So you support them, provide them with respite care, provide them with training, provide them with some psychological care, because you need that sometimes. So just help the people, help your loved ones is probably a fundamental message. And then the third one is the infrastructure part of it. We can't neglect. Let's make care homes that look like homes, that don't look like prisons. That's really fundamental. Let's have people, when I go to, I visited a place in Finland, a home, and they don't wear uniforms. They don't have a long list of here's the things you have to do for the inspector. I went to a home in Canada. They had a 91-page list of standards they had to meet, but not one of them said, are the residents happy? When I go to Finland and I see, what are your standards? Our standards are we care for them like they're our parents. That's the attitude you have to have, and you have to make it staff able to do that. So those are the biggies, and then there's a whole bunch of other smaller things that are not unimportant, but a long laundry list that we have to facilitate those big ones.
I've been calling myself, a caregiver crusader for the past many years, and what I'm really advocating for is education. And I use the prescription of care is truly education. And I think that in order to change the healthcare system, it really starts with how we teach the students when they're at the university level. How are the medical students and nurses and social workers and OTPTs? They deserve to be properly trained, because I think what's happening right now is that they're learning about the disease, but they're not learning about patient person-centered care. They're not learning about the information that once they present the diagnosis, what do the families need? How to talk to them? And I know it's a question of time, because when you talk to the family physicians, they don't have the time. But that's the only way that we're going to change things, because you've got to start at the university level. And I'm very pleased to be part of the 2021 and 2022 World Alzheimer's reports. And next year we're going to be focusing on post-diagnostic care and management, and that's going to come out. And, educating the family members, educating the staff, education plays such an important role.
Yeah, it's all about being prepared, right? That's what education is preparing. I think there's some good news on that front. One of my favorite programs I've ever seen in a medical school is they pair up new medical students are paired with an elder in the community. And that is, I think, the single most important assignment they have. It's like, you're going to be responsible for Mrs. Jones through your entire school career. She's going to be able to call you. Her family is going to be able to call you when they have a problem. And that is an eye opener. When you're a 22-year-old medical student and the family calls you and says, I don't know how to change a continence pad. Can you come and help me? That once doctors have done that, I think it opens our eyes to the reality. The reality is I'm going to prescribe you this fancy drug and stuff. The reality is that's what's hard. That's what people struggle with. And once you have that, I think that empathy, that to me should change the way we care pretty fundamentally for our elders. That's the hope.
Well, André, your book, Neglected No More, I'm going that there we are, is a true gift to the community. And when we talk about education, I think, everyone from the general public to medical students to healthcare professionals should really pick up this book. It's available on Amazon. Is there any other way of getting hold of it? Or
yeah, I think it's available. The saying goes, in fine bookstores everywhere, and even ones that aren't so fine. So I think it's easy to find online. In now that we're starting to go back to stores, it's there. I should mention too, because it's McGill. I wrote a version in French as well. It's called Les Grands Oubliés. So it is available in French. The exact same book, but in the French language. So.
Okay, well, we will definitely be adding your book to the resources section of our website. Thank you so much for taking the time to be with us today. I really, just on a personal basis, thank you so much. It's a real honor and privilege for me to be able to interview you today and hear your story.
And it's likewise an honor for me, and thank you for all your advocacy. It's so important.
Well, thank you. This webcast is an initiative of the McGill Dementia Education Program, which is funded by private donations. Once again, I would really like to thank the Zeller Family Foundation for supporting today's webcast. If you would like to make a donation to our program or for more information, please visit us at mcgill.ca/dementia. And if you would like to join our mailing list to be notified of upcoming episodes of McGill Cares, as well as important programs and resources, please email us at dementia@mcgill.ca. This webcast, if you didn't have a chance to watch it, is available on demand at all times at mcgill.ca/dementia. Thank you for watching.